everybody understands the eye anatomy, right? You want me to go through it again? Oh, thank you. Okay, so age-related macular degeneration is something that I see pretty much every single day, and for, I would say, at least 40% of my patients have this disease. Extremely common. And when we talk about age-related macular degeneration, we talk about dry and wet, okay? The disease starts as dry, and how do we make that diagnosis? Well, it's easy. We see little drusen, little yellow spots that are funny little deposits deep in the retina. So it's pretty easy to make the diagnosis. And as the disease progresses, you go from dry to wet. Sometimes, not everybody will go to wet. So typically when you're first diagnosed, you have dry, but sometimes, like Pat, she presented with wet AMD. Both dry and wet can take away vision, and the way dry takes it away is through atrophy. You get these patches where the retina just thins out, and you lose your photoreceptors, and you see, it's almost, I always tell my patients, it's like Swiss cheese vision. They're missing sections. And so even though they may measure 20/20 on the Snellen acuity, they don't see right, and they're frustrated. And sometimes they're right on because they can make little micro eye movements and see things well, and other days they can't see well at all. So it's a frustrating type of vision. But wet AMD comes on fast, as Pat kind of mentioned, and all of a sudden you may see what we call metamorphopsia, or lines start to bend. Okay, so you look at a straight line, and it's got a bend in it. And that is a sign of macular disease. It's different from like loss of vision from cataracts. A lot of people don't come in because they think, oh, it's a cataract, and I'll get around to it. But cataracts slowly blur your vision and may cause glare. This is different. This is bending of lines, distortion. And so if you see a distortion, get to your doctor right away. Okay, so as dry AMD advances, we start to see more drusen and more pigmentary change, and actual dropout of tissue, which we call atrophy. Excuse me, I'm really struggling with this cold today. AMD is the leading cause of blindness in the U.S. in patients over the age of 50. And 90% of the cases are dry, but about 10% will go to this more advanced form, which we call wet. The reason why we call it wet is because we get abnormal blood vessels growing that start to leak and ooze. And that's what the wet is referring to. So here we go. We start out dry. There's a couple little drusen, a little hard to see in these pictures. And slowly we start to see more of these little drusen. And then we start to see leakage. And the leakage can actually leak blood or edema, as we talked about before. And so here we see blood in the eye, and sometimes the blood can be quite advanced. And if these are not treated, these become fibrotic and scarred, and then you automatically drop to 2200 or hand motion vision. So where do we want to catch it? Well, we want to catch it early. So a lot of patients say, well, there's no treatment for dry AMD. Well, that's wrong, okay? There is treatment. And what we do is genetic testing. And if you haven't had it done, you should. And you can ask your retina specialist about this. It's super easy. We just take a swab, and we swab the inside of the cheek and send it off to a lab where it's analyzed. And why this is important is, number one, this is a spectrum of a disease, okay? And it tells us where you fit into this spectrum, okay? And it divides it into 5 categories, 5 risk categories, where 5 is the worst. So if we pick up patients that are 5, and I do, we really have to stay on top of those patients, because those patients are really at high risk of developing the wet form of the disease. Of course, we worry about pretty much 3 and above, but it gives us an idea of how closely we should monitor this patient and how aggressive we should be in their management. But on top of that, we have found that all these little genes that we look at respond differently to the vitamins. And at first it was thought that The vitamins help everybody. The AREDS vitamins, you probably heard about it, was studied extensively through the National Institute of Health. And the AREDS vitamins are like Preservision and Ocuvite. There's a whole bunch of them out there, Visivite. And they're this complex formula. But what's interesting is that first the message was that everybody needs these, everybody with dry AMD should take these. Now the message is changing, and that they may help you, or they may be a waste of money for you. They may not do anything. But then sometimes they can actually hurt you, and that'll be talked about more in the next lecture. And the component of zinc is really interesting, and sometimes zinc is good, and sometimes it's bad, and it has to do with the complement pathway, which is kind of complex, but it has to do with inflammation in these little genes. The other thing that's really important is when we identify somebody who's high risk, like 3, 4, 5, then we want to start monitoring. And we have a couple monitoring devices. Larry was just showing me one that's online, which I don't know too much about, but I'm going to research it. But the one I've been using with my patients is 4C Home, and this is very well researched, and it's been FDA approved since 2009, and Medicare now pays for it. Medicare doesn't pay for a lot. So you know, if Medicare is paying for it, it probably is a good thing, right? So, so right now there's not much cost to the patient, maybe a small copay depending on insurance, but and like I said, it's been extremely well researched over the years. And what it's designed to do is you play this, you look through this device, actual device. Okay, if you look through a little device like this, and you take this home, and you test yourself every day, and you see a little line that goes quickly, and then it disappears, and you move the mouse to where you saw the little bump, and click. And it collects a whole bunch of information. And then, if you deviate from your baseline, in other words, it detects change, and this uses hyperacuity perimetry, so it's very, very sensitive, much more sensitive than you are. So you won't even pick up these changes, but this instrument will. It actually alerts me. They send me an email and say, hey, this person's in trouble. Go, get them in and take a look. So this helps us identify, get these patients in early before they even notice anything. And if I find something, I'll do the OCT and check them out. And if I find something, I'll start treatment right away. It's amazing. And so, yeah, so this is, I get this information on the internet, and I can see how they're doing, how often they're testing, and where they have maybe microscotomas, or a little loss of vision, like little patchy vision. So a lot of patients have this funny little pattern where they're actually not seeing well in those areas. So it's interesting for me to follow that, and it's a really great way to get the patients in early. So when they cross this little line, I get an alert, and I call the patient and get them in. So you may say, well, like my patients tell me this all the time, I don't want to bother with that. I don't need that. Well, you do, especially if you're in that high-risk genetic profile. So some doctors are still using the Macular grid, which I think is pretty much a waste of time. But if you like the Macular grid and it works for you, that's fine. And basically, it's a piece of grid paper, and you look at it with one eye and then the other eye. And if you notice any distortion, then you come in. But when we researched this, we found that the chances of detecting patients with wet AMD with 20/40 vision or better was 94% as compared to 62%, or as compared to much lower in patients who were just monitoring with the Macular grid. So we were picking up these patients with good vision very early, and that's the key. Because like I said before, if you come to me and your vision has dropped, I have to work really hard to get you up. And we have treatment, but most of the time, the treatment only improves you by 2 lines on the chart, the chart. So you only maybe, so if you come in 2200, I can maybe only get you to 2125. That's not what you want. You want 20/40 vision, right? So if I get you at 2063, I can probably get you to 20/40, which will keep you driving and reading. Does that make sense? Okay, so how do we do 4C Home? You ask your retina specialist for a prescription, we send it in, they call you, and it gets sent to you, and it's very easy to operate, and they help you with all that, so it's easy. So, as I said, Medicare is now covering this, which really helps out. A lot of patients were, on limited budgets, and it's an extra cost every month is hard. But now that Medicare is covering it, it's really good. So you may say, well, what do people really experience when they have wet AMD? What is it like to have vision loss? And I think this slide kind of demonstrates that. So if your vision is 20/30 to 20/60, where you could probably still read and drive, maybe with a limited license, you would see this kind of distortion. And that's not pleasant. Can you imagine every day, every moment of your life, seeing this kind of distortion where everything looks like a Picasso picture, you know? And you're like trying to figure things out. And when you drop to 20/80 to 21/60, it gets even more blurred. And that's when patients will say to me, like, I can't really recognize faces, and I'm embarrassed. And I always say, I think Charlie's message was so good, you know, like you have to just accept what you have and move ahead. Because if you try to hide it, then people think you're funny, you know, like that you're ignoring them or you're aloof or something like that. But if you say, listen, I have a vision problem, I'm sorry to quite see you before, you know, or I sometimes don't recognize you until you speak, and I recognize your voice. That's important, because people do want to help, and people don't want to ask for help, but it really makes a difference in people's lives. And then when you get to 2200 to 2400, now everything is really distorted. And I can understand how frustrating this would be to live every day of your life with a distorted world. I mean, it's horrible. So that's why we want to catch patients early, we want to get them in, and we want to help, because we can help you, so you've got to get in early. So what happens in wet AMD? Well, we have these abnormal blood vessels, and again, this might get a little too technical for you, but we do have nurses and other people who are trained, so I want to get into it a little bit. So this is glycol, right, which is rich in blood vessels, and then we have Brooks membrane, and then we have these abnormal blood vessels that are growing underneath the retinal pigment epithelium, underneath the retina, and they're friable, and they bleed, and they ooze, and they cause problems. So our treatment is geared towards getting these blood vessels to melt away. And this is what, you know, again, this is what we do. We do all this beautiful imaging. Every time you go to the retina specialist, you will be imaged, that's for sure, and it will be dilated. So, you know, if you need a driver, bring a driver. Every appointment, dilation and imaging. That's the way we do it, because we don't want to miss anything. So this is a normal retina, and it's, you know, it's very pretty, as I said before. It's kind of this orangey color. This is the optic nerve. My patients always ask me, what's that big thing in the picture? This is the optic nerve, and this carries the image to the brain where it's decoded as vision. And this is a patient with wet AMD with hemorrhage and exudation. We see this yellow that almost looks like mustard, ketchup and mustard on the retina. That's leakage, okay? So these lesions are very, very leaky, and you can see, like, you're not going to be able to see through all this, right? This is just blocking the photoreceptors, blocking the vision, and destroying that central vision. And the thing about AMD is it affects just this part of the eye. The rest of the retina is fine. The periphery is fine. And that's good, because you'll never be blind like a Helen Keller type blind. You'll always have peripheral vision, which will help you live independently and negotiate your home and things like that. But you know, your macula is what you need to read and drive and do the things that we really love to do in life. So it's an interesting disease. The other thing I always tell my patients is macular degeneration is really limited to the eye, and that's a good thing. You know, there's not a lot of good things to say about AMD, but the one thing I can say is it's really limited to the eye. So it's not like diabetes that affects every organ in the body. So it's very much limited to just this macula. Again, fluorescein angiography plays a very important role in studying these patients. And what we do is we look at how the blood vessels fill and what's leaky. So here we start early. You can see the arteries are just starting to fill. Here there's complete circulation around the retina, and it should be nice and black like this. But in patients with macular degeneration, we see this lesion and it leaks. So it leaks this fluorescein dye, and that helps us make the diagnosis and follow patients with this disease to see how you're responding to drug. Again, the pictures of the imaging is just so interesting. I hope I'm not boring you, but I just find it fascinating to look at these pictures. Again, you see the drusen, the little yellow spots. This is the macula, optic nerve, and you can see how the blood is blocking. You know, it doesn't. You can't see through this. And then this kind of looks. It's like a plane flying over the retina, and this is the cut. This is like cutting the retina, like it's a cake. And here we can look deeper with the OCT, which is so helpful in this disease. And you can see the collections, these large collections of drusen, which get really big. We name them fibrovascular retinal pigment epithelial detachments. You may hear these words when you go to your doctor, that's why I like to mention it. And you see this leakage, this serous fluid that's collecting under the retina, which I call water in the basement. You see all this stuff. And the retina is just lifted. So that makes images look smaller and more distant. So that might be a problem that you're noticing when you have this disease, as well, of course, as distortion and loss of vision. Well, there are risk factors for this disease. This is a genetic disease, okay? It's at least 71% genetic. There are environmental factors, and the environmental factors are critically important. There's no question about that. And it seems that smoking actually triggers some of these little SNPs that we're going to talk about, these little gene segments that we're going to talk about. So smoking is just bad, okay? And there's many reasons to quit smoking, but anyone with AMD should not smoke, and they should tell their children not to smoke as well, okay? The other thing we know is that there is this cardiovascular link, so a healthy lifestyle is so very, very, very important. Women get this disease more often, and it seems like a lot of the women present a little earlier. It seems like most of my patients who present in their 50s are women, and they get really aggressive disease, so I have to really take careful care of these patients. And the genes are more common in Caucasians. It seems to cluster around Northern Europeans, things like that. So again, we have this very strong genetic component. Exposure to sunlight. Sunlight is harmful to the eyes, okay? It causes cataracts. It can definitely cause lid lesions, basal cells and squamous cell cancers. And it causes macular degeneration. It can make macular degeneration worse. So it's very, very important to protect yourself from the sun with a hat. If you're golfing, please wear a hat, please wear your sunglasses. I see a lot of golfers and tennis players who don't do this. It's not good. Okay, so what are our treatments? Okay, again, what's kind of makes my life simple is that we use the same drugs to treat a lot of diseases. So when I'm using my drugs, I can use them quite often. And again, it's these anti-VEGF. And VEGF is vascular endothelial growth factor. It's a very important factor that causes leakage of these blood vessels and growth of these abnormal blood vessels. So we block it. We block it with biologics. We have 3: Avastin, Lucentis, Eylea. They all work really, really well. Some doctors prefer one over the other for different reasons. Sometimes insurance tells us Avastin is the cheapest, so sometimes insurance companies will make us use Avastin, which is fine. It's a great drug, no problem with that. But we do have 3 choices. And sometimes your doctor may switch you. He or she may start you with one and switch to another, hoping for a better result. So if that comes along, that's okay. We do that quite often. And again, I reviewed this in the first lecture, so I don't think I'll go through it now, but these are these little antibodies to this biologic and to this molecule, and that is how we treat this disease. Again, a lot of my patients say, well, is it safe? Has it been studied? Yes. And it's been well studied. I participated in many of these studies. These are phase 3 studies to get FDA approval. It's very hard to get FDA approval. You have to do 2 sister studies and quite a few patients. And these are world studies, not just in my office, but not just even in the United States, but they're world studies. So they're being studied in centers across the world. And we learn a lot from these studies. But safety is always our major concern. And this was a really important study, and I know I'm getting a little techie here, so I won't spend a lot of time on this, but this was kind of a groundbreaking study because this was the first time we were actually able to make patients see better. Prior to this, we would do lasers. Some of you may have had PBT laser, and the patients did not do well. They lost vision. But when we gave these drugs, this study is actually with Lucentis, which is a Genentech drug, they saw better. And they saw quite a bit better. And they saw better fast. You can see within 1 month of treatment, they were improving. And I always think, thank God for that, because I don't think I'd be able to talk somebody into a second injection if they weren't seeing better. So they come back and they see better. They look at the OCT starts to look drier. It starts to come down. It's not as thick. The blood starts to clear, and everybody's happy. And that's great. So again, you can see many of these patients were gaining 15 letters or more, which is 3 letters on the Snellen acuity chart, so you read 3 lines better. And we use ETDRS now because it's more scientific and it's better for measuring vision. So the ETDRS chart is probably the one you're reading off of now when you go in and have your doctor checked, your vision checked. So how do we put all this together? So a patient comes in, here's a very typical patient, a lovely middle-aged woman who's an artist, she travels, she golfs, and like many people in this room, and she has family history of AMD. She starts out with dry AMD, we do the genetic testing, we find she's high risk, we figure out what vitamin she should be on, we put her on the vitamin, sign her up for 4C home, and lo and behold, she changes. She goes from dry to wet, okay? And we get the alert, we start the treatment, and this is how she looked when she came in. This is before this is with the dry, and you can see a couple drusen, but there's no edema, there's no fluid in the retina, there's no blood. Then she comes in here, we get the alert, we have her come in, we do the OCT, and look, there's a difference, right? And you guys aren't experts on reading OCT, but you can see this, right? Suddenly, the retina's thick, there's fluid in the basement, right? Serous fluid, like I talked about before. These big deposits, and this is the little cluster of blood vessels, and it's leaking. And it's leaking in the retina, it's damaging the retina, it's causing this elevation. We start injecting, and this is what we get now. So we see the fluid dry up with these injections. It's really incredible. So, but the thing is, you may need more than 1 injection. Okay, we don't know, and that's the biggest question. I've been pondering this for a long time. When patients come in, they always want to know, well, how often do I have to come? How long is this going to go on for? And we can't tell from the get-go who's going to need 1 injection and who's I'm going to inject for the next 10 years, every 5 to 6 weeks. And I have patients like that because these drugs became available in 2005. So I have patients that I started treating back then, but you know what? I maintain their vision. And that's the thing. If you want to see, you get the injections. So you may say, well, you know, your treatment seems to be working. Why do we need any more research? Well, again, if I can find a drug where I don't have to inject every 5 to 6 weeks or 7 to 8 weeks, that would be better, right? No question about it. And that's where our research is going. We're looking for drugs that last longer and maybe have an easier way of being administered instead of injections in the eye. Wouldn't it be great to take a pill or inject one of those little pellets that I showed you before that last couple of years? And that's where we're going with our research. I'm involved in many phase 3 studies, and this is one of the studies I'm doing with Allergan, actually, and it's a DARPin. It's a new class of molecules. It's very cool. And again, I don't want to get too techy with you guys, but for those of you who are interested in this stuff, it offers something beyond the anti-VEGF drugs. And it's a tiny little molecule, gets absorbed into, which is good because it gets absorbed into the retina quickly, and it's a very potent antagonist to all forms of VEGF-A, which is the molecule we're trying to block. So it looks very promising, and the results are not out yet, so I don't know for sure. But it looks like some of these patients may be able to go longer than 5 weeks. They may go 2 months or even 3 months after an initial couple of dosing. So sometimes we give 3 doses in the beginning, give it monthly, and then we try to spread it out. So that's what we're looking at now with this drug. We'll see. This is another study I'm involved in with an agent called RTH-258. It hasn't been named yet. Phase 3 study. This is it's still the same class of drugs. It inhibits anti-VEGF, but it's very potent. It's a little molecule, and again, it's the same thing. We're seeing if we can give her some initial dosing every month, maybe for 3 months, and then spread these patients out for 2 to 3 month dosing. That would be great. When they actually come to your retina specialist every 3 months instead of every 6 weeks. That would be good. So we'll let you know about that. Stem cell transplantation is something that I actually did some initial research. It was animal research because it was, that's kind of where we're at now. We're starting to do it in humans. Be very careful. There's a lot of quacky stuff going on out there. Make sure if you go into a study, this is for patients with pretty severe disease. Okay, we're not talking about 2040, 2080. We're talking about 2200. Again, this is not FDA approved. You should go into a trial if you want this. There's a few trials going on across the country. It does require surgery. for the most part, and the idea is to take some undifferentiated cell from somewhere in the body, and there's a lot of sources for these. And one thing that's kind of cool is you can actually get them from the iris. So you might be able to harvest these cells, grow them in culture, and then inject them in some way into the subretinal space. Again, this is very, very preliminary. It's not for most people, but it might be for a few, and the research is going on at major academic centers. Again, this is the idea. You take these cells, you differentiate them, and then inject them back. If you're interested in trials, you can look online, clinicaltrial.gov, and that gives you all the trials that are going on that are sanctioned through the FDA. So they all have to be registered if they're going to get FDA approval. And if you want to go that route, check it out. Okay, it's very, very important that you find the right source and you get into the right kind of trial. And it will also give you a lot of information as to what kinds of patients they're enrolling. So people bring articles to me all the time, my patients, and I appreciate that. And if you have an article, something you're interested in, bring it into your doctor, talk to your doctor about it. It may work for you, it may not work for you. I'm always happy to review the articles, but that's something that you should think about doing. So again, what's really important with AMD? Early detection, right? Get to your doctor. Okay, that's the most, don't think it's a cataract, don't think, well, I'll get around to it, I'm busy with grandchildren. No. You call your doctor, you get it, and if the doctor, again, we have a receptionist, and she says, oh, the doctor's very busy, she can't see till, 3 weeks, and you say, no, I need to get in, okay? So if you ask twice, you'll get in. You call twice, you'll get in. Practices are busy, that's the realization of medicine in our country. So sometimes you have to push the issue a little bit, So, we have good treatments. We have treatment for dry and we have treatment for wet. Okay, it's very, very important. It's all about early detection. Okay, it all comes down to catching it early, as with any disease in your body, right? That's why we go for screening. We look for preventative treatments. That's what it's all about. And again, the vision that you come in with is kind of tells me where I can take you. So if you come in with good vision, I can keep you there, I promise. But if you come in with bad vision, it's very tricky for me. I can probably only get you a little better. So we want to get you in, and we want to start these injections right away. Don't smoke. Okay, I tell patients all day long, every day. I don't think anyone ever quits. I think I have a 0% quitting rate, but I just keep telling them, and maybe at some point a lot of patients tell me flat out, I'm not going to quit, so just don't even go there. So, it's very tricky, but I always try. My patient made this for me. She has wet macular degeneration. I've been injecting her for a long time. It's hard to tell from the slide, but this is fine needle point. It's actually cruel. And that's why people do cruel anymore. She has to buy these kits on eBay because they don't make them. But it's all fine little stitching. And I think it just shows you, what you can do if you just, keep up with your vision. So,